All right, let's go. Number 10. Morphine Syrettes. In the spring of 1943, a combat medic was doing what combat medics do in the minutes after a soldier goes down. He was moving. He was moving toward the sound and toward the man, and he was opening his kit as he moved, because opening the kit while moving saved seconds and seconds were the unit of measurement that mattered in what he was about to do. The wounded soldier had taken shrapnel in the left thigh and was making a sound that an experienced medic learns to assess from a distance for what it communicates about severity. The kit contained, among other things, a small metal cylinder approximately the length of a finger with a needle at one end and a collapsible tube at the other. The cylinder was preloaded. The needle was sterile. The compound inside the tube was morphine sulfate. The needle was uncapped. The tube was pressed against the casualty's thigh. It was squeezed. The empty cylinder was then pinned to the lapel of the casualty's jacket so that the next medic who reached him would know not to administer another dose. The casualty's breathing changed within 90 seconds. The sound he had been making stopped. The medic moved to the next man. In the Pacific and European and North African theaters simultaneously, thousands of men were performing the same sequence that morning, millions of times across the war. What the Syrette actually was, as an object and as an institutional decision, is worth holding separately from the medical emergency it was designed to address. The preloaded single-use injectable morphine unit was developed through wartime military pharmaceutical procurement and manufactured by Squibb among other suppliers, adopted for mass distribution to combat medics on the specific grounds that a medic with 60 seconds and no sterile conditions and a wounded man who could not wait needed a delivery mechanism that required no preparation, no measurement, and no training beyond the minimum. The collar pin protocol, unpinning the used Syrette and pinning it to the casualty's clothing, existed because the overdose risk from a second injection was considered significant enough to require a physical warning system attached to the patient's body. The engineering of the Syrette reflected two specific concerns: reliable delivery in field conditions and prevention of accidental overdose. The engineering did not reflect a third concern, because the third concern was not in the design brief. The third concern was what happened to a nervous system that had learned to require morphine when the morphine stopped. The collar pin protocol addressed the memory of the next medic. It did not address the memory of the nervous system that had received the first injection. What soldiers who received multiple Syrette administrations across a sustained campaign experienced is reconstructible from field medical records and post-war VA documentation. A soldier wounded in the field received a Syrette from the combat medic. He was moved to a battalion aid station, where the wound was assessed and another injection was administered if the pain required it. He was moved to a regimental collecting station, and another injection followed if the evacuation had been long. He reached a field hospital, where he went into surgery under a different anesthetic compound and where the post-operative pain management began another phase of opioid administration. A soldier who moved through that evacuation chain across an extended period had received opioid administration at multiple points from multiple sources by multiple military medical personnel, none of whom had a complete picture of his total opioid exposure. The collar pin addressed the problem of the next medic not knowing about the first injection. It did not address the problem of the field hospital not knowing about the battalion aid station. Millions of Syrette administrations across roughly 900,000 total American combat casualties, killed and wounded combined, reveals that administrations significantly exceeded single administration acute wound management. Multiple administrations per patient. Administration for conditions that were not acute traumatic wounds. Administration in the evacuation chain at points where the acute pain management rationale had been extended into post-acute management in the absence of alternatives. David Musto at Yale, in The American Disease published in 1973, examined the broader history of narcotics in America and noted that post-war studies showed opioid dependency rates among combat veterans elevated above the civilian baseline, a pattern connected to battlefield opioid exposure during the war. But here is where the standard explanation falls apart. The collar pin protocol is the evidence. It is the evidence of what the institution had thought about and what it had not. The overdose risk was anticipated and addressed with a piece of physical engineering attached to the patient's body. The dependency risk was not anticipated and therefore not addressed with any mechanism, not physical, not administrative, not medical, not in the training of the medics who administered the compound, and not in the intake protocols of the VA that received the men who had received the compound. The institution that designed the collar pin was a sophisticated institution. It understood overdose. It did not understand, or did not prioritize, the question of what a man who had received morphine repeatedly over weeks and months would experience when he went home and the morphine stopped. The Syrette was designed to get a man off the battlefield. What it also did was follow him home in the only way that a drug follows a person, which is from the inside, in the nervous system that had learned during the war what the war was providing, and that continued to know what it had learned long after the war had ended. Number 9. Demerol. In 1938, two pharmacologists named Otto Eisleb and Otto Schaumann, working at the Hoechst Laboratories, part of the IG Farben network near Frankfurt, were reviewing the trial data for a new synthetic compound their team had synthesized and were recording observations that would be cited for the next 2 decades as the scientific foundation for meparidine's safety profile. The compound had been developed originally as an antispasmodic, a treatment for smooth muscle spasm in the gastrointestinal tract, and its analgesic properties had emerged as a secondary finding during trials aimed at the antispasmodic application. The analgesic effect was significant. The antispasmodic effect was real. What the researchers wrote in their publications about the compound, specifically the observation that it produced less smooth muscle spasm than morphine, was not an observation about reduced addiction potential. The distinction between those two things, between reduced spasm and reduced dependency, is not a subtle distinction. The distinction did not survive the journey from research publications to military pharmaceutical formulary intact. How Demerol came to be adopted by Allied military medicine as a safer alternative to morphine is a story about how scientific claims travel through institutions. The original research showed that mepridine produced less smooth muscle spasm than morphine, which was medically relevant because morphine's spasm-inducing properties produced constipation and urinary retention that complicated surgical care. The reduced spasm finding was real and clinically important. At some point in the journey from the Hoechst research publications to the Allied military pharmaceutical procurement system via the wartime pharmaceutical intelligence operations that moved German research into American military medicine, the reduced spasm finding was translated into a reduced addiction potential claim. The translation was not supported by the research. No addiction-specific controlled trial had been conducted on meperidine. The safety claim was an extrapolation from a pharmacological observation about one property of the compound to a conclusion about a different property of the compound. The extrapolation was made by people who needed a synthetic opioid that was safer than morphine and found a claim that said they had one. What Demerol actually does pharmacologically explains why the false safety claim produced real dependency in the soldiers who received it. Meperidine binds to mu-opioid receptors with the same mechanism that morphine uses, producing analgesia through the same pathway and dependency through the same pathway. The belief that it was less addictive was based on a misreading of the receptor pharmacology. Meperidine's shorter duration of action was interpreted as evidence of faster clearance and therefore reduced accumulation. The interpretation was incorrect. Shorter duration of action means more frequent dosing to maintain analgesia, which means more frequent receptor stimulation, which means dependency develops at rates comparable to morphine rather than at the reduced rates the safety claim predicted. Meperidine also produces a toxic metabolite, normeperidine, that accumulates with repeated dosing and causes a specific toxicity profile including anxiety, agitation, and seizures that was initially interpreted in post-war VA settings as combat-related psychological disorder rather than as a pharmacological consequence of the compound they had received. Post-war clinical reviews eventually established that the wartime medical literature had consistently overstated Demerol's safety advantage over morphine, and that the clinical evidence for reduced addiction potential was never established by controlled trial but was extrapolated from a single pharmacological observation. The modern trace of Demerol's wartime adoption is the trace that makes it the most historically significant item in terms of what it started rather than what it was. The 1940s, confidence in meperidine as a safer synthetic opioid is the first iteration of a pattern that the 20th century repeated at roughly 20-year intervals with different compounds in the same institutional logic. The 1970s confidence in propoxyphene, the 1990s confidence in OxyContin, whose manufacturers claim that its extended-release formulation prevented addiction, was the 1990s version of the 1930s, observation extrapolated beyond its evidence. Each iteration involved a synthetic opioid, a safety claim derived from a real pharmacological observation, an absence of addiction-specific controlled trial evidence, a military or medical institutional adoption at scale, and a post-war or post-adoption dependency epidemic whose scale the safety claim had made invisible until it was too large to manage. The pattern is still running. Demerol was not the cause of the pattern. It was the first time the pattern ran through a government medical institution at the scale of an army. But here is where the standard explanation falls apart. The standard account presents the Demerol adoption as a good faith medical error, a scientific community that believed a safety claim that turned out to be wrong. What post-war analysis established is that the safety claim was never tested in the way that would have been required to verify it. A controlled addiction trial would have tested the compound in human subjects over an extended period with dependency as the primary outcome measure. No such trial was conducted before the wartime adoption. The compound was distributed to wounded soldiers across Allied theaters on the basis of a claim derived from a different trial, measuring a different outcome in a different context. The good faith error was not an error about what the trial showed, it was an error about what the trial had tested. The institution needed a compound and found a claim. The claim had a research citation. The institution did not read far enough into the research to find what the citation actually supported. Demerol was the first synthetic opioid promoted as safer than what it replaced. It was not the last. The pattern is still running. Number 8. Chloral Hydrate. The same compound. That is the opening impossibility of this item, and it requires a moment to hold before moving on. The compound that gave criminal slang its most durable pharmaceutical term, knockout drops, whose use to incapacitate victims without their knowledge was prosecuted in criminal courts across 3 continents in the 1930s and 40s, was simultaneously the compound that military physicians across all theaters of the Second World War were prescribing to soldiers with combat-related insomnia as a safe and non-habit-forming sleep aid. Chloral Hydrate. The same molecule, the same pharmacological action, the same physical dependency profile, prescribed in one context by criminals who understood exactly what it would do to the person receiving it, and prescribed in another context by physicians who believed it was harmless. The criminal and the physician were using the same compound. The difference between the two situations was consent and stated purpose. The pharmacology was identical in both cases. What chloral hydrate's dual reputation looked like in the 1940s is a study in the institutional psychology of chemical knowledge. In criminal courts, chloral hydrate was understood with precision, a compound that produced rapid sedation, that was difficult to detect in a drink, and that left the recipient with impaired memory. In medical textbooks, chloral hydrate was understood as a legitimate sedative hypnotic, with a history of use since its introduction in the 1860s, and a dependency profile that the textbooks described as moderate and clinically manageable. Both descriptions were accurate. The criminal courts understood the acute effects. The medical textbooks described the chronic dependency. The prescribing physician who reached for chloral hydrate as a sleep medication for a soldier with combat insomnia was drawing on the medical textbook understanding and not connecting it to the criminal court understanding, even though the two descriptions were about the same compound, and the dependency the textbook acknowledged was the same pharmacological property the criminal context was exploiting. What combat-related insomnia actually was and felt like in the field is worth describing because it is the condition that the prescription was addressing, and the condition shapes the prescription. Combat soldiers experiencing hypervigilance, the persistent state of threat alertness that sustained combat produces, cannot safely achieve the unconsciousness that sleep requires, because the nervous system trained to remain alert experiences unconsciousness as a threat condition. The soldier with combat insomnia receives a compound called a safe and harmless sleep aid from a physician he trusts in a uniform that represents institutional authority, and takes the compound without being told that its safety profile in the medical textbooks includes a dependency clause that the prescribing physician has decided is not relevant to his clinical situation. Researchers at the Public Health Service Addiction Research Center documented in the early 1950s that physical dependency and a clinically significant withdrawal syndrome were produced by chloral hydrate in chronic users, and that the compound had been prescribed to military personnel across the war on the incorrect assumption that it did not produce physical dependency. How VA physicians identified chloral hydrate dependency in veteran populations after the war is a diagnostic story that the official record tells incompletely. The presenting symptoms in the VA setting were anxiety, insomnia, tremor, and in severe cases, psychotic episodes. Those symptoms were also the presenting symptoms of combat-related psychological trauma, which was the primary diagnosis being applied to veterans presenting with psychological distress in the immediate post-war years. The differential diagnosis between chloral hydrate withdrawal and primary psychological disorder required a medication history that included chloral hydrate use, and the medication history required the VA intake process to ask about it, and the VA intake process was designed around the assumption that the compounds veterans had received were the ones in their formal military medical records. Chloral hydrate prescribed by a field physician frequently was not in the formal military medical record because the record-keeping standards of field medicine did not require documentation of every pharmaceutical dispensed under routine treatment protocols. But here is where the standard explanation falls apart. The dependency risk of chloral hydrate was not unknown in 1942. The 1880s medical literature described it. The 1920s medical literature confirmed it. The prescribing physicians who dispensed it to soldiers as a safe and non-habit-forming sleep aid had access to literature that documented the dependency potential in language whose clarity left no room for comfortable reinterpretation. The belief that it was non-habit-forming was not derived from the literature. It was derived from a clinical tradition of prescribing chloral hydrate in acute contexts where the prescription period was short enough that dependency did not typically develop. A tradition that was extrapolated into the military context where the prescription period was as long as the campaign and the acute context had become a chronic one. The courts prosecuted people for administering chloral hydrate without consent. The military prescribed it with consent that was based on incomplete information about what was being consented to. The compound did not distinguish between the two situations. The nervous systems of the people who received it did not either. Number 7. Wehrmacht Codeine. In the summer of 1944, an American medical officer was moving through a captured German field medical depot somewhere in northern France, taking an inventory of what the retreating Wehrmacht had left behind. The task was administrative in the specific way of a competent officer doing a thorough job under conditions that did not particularly encourage thoroughness. He was working through the crates systematically, noting quantities and compound names, when he opened a crate that he would write about in his report to Allied Medical Command, with language that was careful and specific and that carried, beneath its clinical precision, the unmistakable quality of a person who has found something he does not know quite how to account for. The crate contained codeine phosphate tablets. The quantity was not the quantity of an acute wound management supply. The quantity was the quantity of a chronic treatment program. The prescription records accompanying the crate confirmed what the quantity had suggested. The German military medical system had been managing chronic pain across its entire operational scope, with a systematic codeine distribution program whose scale had no equivalent in American military medical practice. What Allied medical officers found in captured German field medical supplies across the European theater in the final year of the war produced a specific kind of document in the Allied Medical Command files, comparative pharmaceutical assessments that attempted to characterize the difference between German and Allied military medical philosophy in terms that were clinically precise and institutionally diplomatic. The Allied Control Commission Medical Division's report on captured German pharmaceutical supplies from 1945 confirmed that Wehrmacht field medical units maintained codeine phosphate stocks at levels significantly exceeding acute pain management requirements, and that prescription records indicated systematic chronic administration rather than acute wound-based dispensing. The codeine distribution was consistent across multiple German army groups. The prescription records showed systematic administration to soldiers with chronic pain conditions, not acute wound management but ongoing treatment for the musculoskeletal injuries, the frostbite sequelae, the nerve damage from blast and shrapnel, that soldiers in prolonged campaigns accumulate. The Wehrmacht had built a chronic pain management program. The program used codeine phosphate. The prescription records tracked distribution. The prescription records did not track patient outcomes. What codeine does pharmacologically explains why the captured records showed systematic distribution without showing the consequences of systematic distribution. Codeine is a prodrug converted to morphine in the liver by the CYP2D6 enzyme, which is the pharmacological mechanism that produces its analgesic effect. The conversion rate varies between individuals because CYP2D6 activity is genetically determined, meaning the same dose produces different levels of morphine exposure in different patients. The dependency that develops with chronic codeine use develops through the same mu-opioid receptor mechanism as morphine dependency, but at a slower rate, and with a withdrawal syndrome that presents with less intensity than acute morphine withdrawal. The slower development and lower intensity were the reasons codeine was classified as a lower-risk opioid in the 1940s medical literature. The classification was not wrong, it was incomplete. Lower risk than morphine is not the same as no risk. Systematic chronic administration of a lower-risk opioid to a large population produces dependency at scale. The Wehrmacht's pharmaceutical records were meticulous about what went out. They contained nothing about what that distribution produced in the bodies that received it. The class dimensions of the Wehrmacht codeine distribution reveal something about the institutional logic of the program that the prescription records cannot fully characterize. Officers received physician-managed chronic pain treatment with documented prescriptions and follow-up consultations. Enlisted personnel received codeine tablets from field medics under over-the-counter protocols that generated less documentation and less oversight. The enlisted soldier who received codeine from a field medic did not have a prescribing physician managing his dose or assessing his developing tolerance. The dependency that developed in each population developed through the same pharmacological mechanism. The ability to identify and manage the dependency was not equally distributed between them. But here is where the standard explanation falls apart. The Allied assessment that documented the codeine distribution at levels significantly exceeding acute pain management requirements was filed in the Allied Medical Command archives. It did not, in any systematic way, inform the post-war German medical system's encounter with veteran codeine dependency, which was occurring simultaneously with everything else the defeat had produced: physical reconstruction, food scarcity, displaced populations, and the psychological aftermath of a war that had ended in occupation. The tablets were in the crate, the records tracked the distribution, the patient outcome data was absent because it had never been created. A dependency program without a surveillance system is not a medical program, it is a distribution program. The Wehrmacht built a very efficient distribution program. Number 6. Laudanum in the Pacific. In the monsoon season of 1942, a British naval surgeon was treating a wounded soldier at a forward dressing station on the Arakan coast of Burma when he reached into his medical supply box for the analgesic he needed and found the category empty. The modern compound, the standardized pharmaceutical preparation that the base hospital formulary specified and that his training and his clinical judgment both required for this patient's condition, had been exhausted. The resupply had not arrived. What remained in the supply box, in the position reserved for the compound that was supposed to be there, was a different bottle. The bottle was brown glass with a paper label. The label was printed in the typography of an earlier era. The surgeon read the label. The label said laudanum. The tincture of opium and alcohol that the Victorian pharmacopoeia had produced as the primary pain medication of the 19th century was in the forward dressing station supply box on the Arakan coast of Burma in 1942, because the supply chain for that dressing station had not been audited and updated to reflect the decades of pharmaceutical development that had occurred between the Victorian pharmacopoeia and the Second World War. The surgeon administered the laudanum. He had a patient who needed pain management, and this was what there was. How laudanum remained in active military medical supplies into the 1940s is a story about institutional inertia as a pharmaceutical policy. The Victorian pharmacopoeia was not abolished when the 20th century began. Compounds that had been in military medical kits for decades remained in military medical kits through the combined effects of procurement bureaucracy, supply chain conservatism, and the specific geography of a military supply system, in which the further from the main base, the older the supplies. The British military pharmaceutical formulary had been updated for base hospitals and for the major theaters. The updates had traveled down the supply chain with the slowness characteristic of updates in large bureaucratic systems under wartime pressure. At the far end of the supply chain, at the coastal dressing stations of the Arakan and the jungle-clearing aid posts of the Burma campaign, the formulary operating in practice was not necessarily the formulary operating on paper. British military medical histories confirmed that laudanum remained a listed item in certain British military medical supply categories into the early years of the war, and that its presence in forward area medical kits in the Burma and Arakan theaters was documented in medical officer reports. What laudanum actually is requires more than a Victorian association to understand pharmacologically. The tincture of opium and alcohol, approximately 10 milligrams of morphine per milliliter, with additional opium alkaloids including codeine and noscapine in a base of alcohol and flavoring agents, produces analgesia through the same mu-opioid receptor mechanism as pharmaceutical morphine, with the additional pharmacological variable of the alcohol content and the dose uncertainty that an uncontrolled concentration plant preparation introduces. A pharmaceutical morphine preparation has a known and verified morphine concentration per unit dose. Laudanum from a period production batch does not have a verified morphine concentration per unit dose in the sense that the batch was not produced to the standardization specifications that pharmaceutical production requires. The field surgeon administering laudanum from a bottle with a pre-First World War production date was administering an analgesic whose dose was approximately correct rather than precisely known. The dependency that developed with repeated administration was not approximately risk-free in proportion to the dose being approximately known. What British and Commonwealth medical officers recorded about dispensing laudanum in the field is the most revealing part of the documentation because of what it does not say. The accounts in medical diaries and regimental histories treat laudanum administration as an unremarkable clinical event because for the medical officers writing them, it was unremarkable. The compound was in the supply. The patient needed pain management. The compound was administered and the administration was noted in the medical record in the same language that would have been used for any other analgesic dispensed for the same indication. The absence of commentary is the commentary. These were trained physicians administering a Victorian-era compound in a 20th century war and recording the fact without pause or qualification because the supply chain had placed the compound in their kit and the patient needed what the compound provided, and the alternative was no treatment, and no treatment is not a medical option that a physician with a compound in his kit can choose. But here is where the standard explanation falls apart. The supply chain delay framing that presents laudanum's continued presence as a logistical anomaly misrepresents the systematic character of the geographic distribution. The documented cases were not randomly distributed across the Pacific and Indian Ocean theaters. They were concentrated at the forward positions furthest from the supply chain's main arteries, following the exact pattern that would be expected from a supply chain update that had not reached its furthest nodes. This is not an anomaly. This is the supply chain working as supply chains work, which is to say, efficiently at the center and inefficiently at the edge. The soldiers at the edge of the supply chain's reach received the pharmaceutical century's discards because the pharmaceutical century had not prioritized getting its current formulations to the place where those soldiers were. The Victorian compound and the 20th century soldier met at the edge of the supply chain's reach. Neither of them chose the meeting. Both of them felt its consequences. The supply chain did not follow them home to explain. Number 5. Atabrine. Non-compliance rates with mandatory Atabrine administration at times reached 30% or higher in parts of the Pacific Theater, a compliance failure that the military addressed through forced observed administration and that produced, in the process of addressing it, a pharmaceutical pathway to opioid dependency that no one in the military medical system had designed and that no one in the post-war VA system had been told to look for. The soldiers who refused Atabrine were afraid of a side effect that was not real. The compound did not cause impotence. The soldiers who complied with Atabrine received treatment for the side effects that were real, the severe nausea and vomiting and abdominal cramping that quinacrine produces in the gastrointestinal system. This treatment frequently included Paregoric and other opium-based compounds for gastrointestinal complaints. The men who disobeyed the order risked malaria. The men who obeyed it entered a pharmaceutical pathway whose dependency consequences have never been fully quantified in the published literature. The military recorded both outcomes in different departments. The connection between the mandatory order and the dependency risk it created was not a connection the institution was organized to make. Atabrine does what it does to malaria parasites through a mechanism that is specific and effective, and that the compound does entirely apart from what it does to the gastrointestinal system of the human being taking it. Quinacrine intercalates into parasitic DNA, disrupting the replication that allows the parasite to maintain its presence in the bloodstream. This mechanism works. It was the most effective anti-malarial available in the Pacific Theater in the years before synthetic alternatives became available. What the mechanism does not do is prevent the quinacrine molecule from accumulating in subcutaneous tissue and turning the skin yellow, which it does because the molecule has a high affinity for tissue binding and because daily administration produces steady-state tissue concentrations that are visible through the skin. The yellow discoloration was real, harmless, and reversible when administration stopped. The impotence it was rumored to cause was not real and was not harmless as a belief, because the belief produced the compliance failures that produced the enforcement response. The compound's actual gastrointestinal side effects, which were documented and significant, created a clinical justification for opium-based treatment of those symptoms in the field. What Pacific Theater soldiers receiving opium-based treatment for Atabrine side effects experienced represents a specific variant of the dependency pathway worth distinguishing from every other item on this list. Every other item involves soldiers who received opioids because they were wounded or because they had a primary illness. The Atabrine pathway, to the degree it has been reconstructed from field medical records, produced opioid exposure in soldiers who were healthy. Soldiers who had not been wounded. Soldiers who were taking a mandatory preventive medication and receiving opium-based compounds for the gastrointestinal side effects of that medication. This pathway, it must be acknowledged, has not been systematically quantified in any published study. The direct causal chain from mandatory Atabrine compliance to gastrointestinal opioid treatment to widespread dependency is a plausible but under-documented connection, supported by the documentary evidence of both Atabrine's side effects and Paregoric's routine use in Pacific Theater medicine, but its scale remains unestablished. What can be said is that the pathway existed. How many men it affected remains an open question that the post-war medical system was not organized to answer. The Atabrine program required men to take a compound daily or face court-martial. The compound reliably produced gastrointestinal symptoms in a significant proportion of those who took it. The gastrointestinal symptoms were treated with the compounds available for gastrointestinal treatment in the Pacific Theater, which included Paregoric and, in severe cases, morphine. The men who followed orders and took their Atabrine and received opium-based compounds for its side effects were not receiving the opioids because they had been wounded. They were receiving them because their compliance with an institutional requirement had produced a medical consequence that the institution then treated with an addictive compound. Whether the institution understood this chain when it was occurring is not clear from the surviving records. What is clear is that the institution had not designed any mechanism for tracking what the chain produced in the veterans who emerged from it. But here is where the nightmare begins. The men who disobeyed the Atabrine order and contracted malaria were documented as malaria casualties, treated as malaria casualties, and their post-war health consequences were assessed against their documented malaria history. The men who obeyed the Atabrine order and received opium-based compounds for its side effects were documented as compliant soldiers who did not contract malaria. Their post-war health consequences were assessed against a medical history that showed health rather than treatment, compliance rather than exposure, obedience rather than illness. The institution recorded the compliance. It did not record what the compliance had cost. The medical record that the compliant soldier carried out of the Pacific and into the VA system showed a healthy man who had done what his institution required. The nervous system that the compliant soldier carried showed something the medical record did not. The institution recorded the compliance. It did not record what the compliance had cost. Number 4. Sodium pentothal. In the winter of 1943, a surgical nurse was preparing the induction agent before an operation at a forward hospital somewhere in Italy. She was drawing sodium pentothal into a syringe from a vial, the same sequence of actions before every surgical case. The uncapping of the vial and the drawing of the compound into the syringe, and the checking of the dose against the patient's weight, and the preparation of the administration line. The procedure was standard. The compound was the standard induction agent for surgical anesthesia across Allied military hospitals. The patient on the table was a wounded soldier who needed surgery, and who would receive the compound and lose consciousness within seconds of its administration. In a different building at the same facility, used for a different institutional purpose by a different chain of command, the same compound was being drawn from an identical vial into an identical syringe for a different kind of procedure on a different kind of subject, whose name was in a different kind of file. The compound in both syringes was identical. The institutional frameworks governing the two uses were not in the same building, or the same chain of command, or the same ethical architecture. How sodium pentothal came to occupy both syringes simultaneously is a story about the specific properties of barbiturate pharmacology and about what happens when a compound with a specific pharmacological effect is adopted for two different institutional purposes simultaneously. The compound had been developed in the early 1930s as a surgical induction agent, replacing ether and chloroform for the rapid induction of unconsciousness that surgical anesthesia requires. The specific property that made it valuable for surgical anesthesia, rapid onset of deep unconsciousness at injectable doses, was also the property that made it interesting to pre-war psychiatrists who were using it at sub-anesthetic doses to produce a disinhibited state in patients that facilitated disclosure in clinical settings. During the war, military intelligence services began experimenting with it as an interrogation aid on the basis of this clinical observation, reasoning that a compound that reduced verbal inhibition in psychiatric patients would reduce verbal inhibition in interrogation subjects. The reasoning was not entirely wrong. The compound did reduce verbal inhibition. What the intelligence use of this reasoning missed was that reduced verbal inhibition is not the same as truth-telling, and that the state produced by sub-anesthetic barbiturate administration is a state of reduced discrimination rather than increased veracity. What sodium pentothal does as a barbiturate to the nervous system of a patient who receives it repeatedly is the pharmacological dimension that neither the surgical use nor the intelligence use was tracking systematically. The compound potentiates GABA-A receptors, the primary inhibitory neurotransmitter system, which is the same mechanism that alcohol and benzodiazepines use to produce sedation. Physical dependency develops with regular GABA-A potentiation through receptor downregulation, in which the nervous system responds to sustained potentiation by reducing receptor sensitivity, requiring increasing doses to produce the same effect, and producing a withdrawal syndrome when administration stops. The sodium pentothal withdrawal syndrome includes anxiety, insomnia, tremor, hypersensitivity to stimulation, and in severe cases grand mal seizures that were, in the post-war period, fatal in patients who did not receive appropriate medical support. The withdrawal syndrome was clinically indistinguishable from combat-related anxiety disorder to a VA physician who did not know about the repeated surgical inductions and who was not aware that the patient had received the compound in context that the medical record did not fully document. The classified dimension of sodium pentothal's wartime use prevented the two bodies of consequence, the surgical dependency complications and the intelligence use psychological effects, from ever being systematically assembled in a single assessment. Post-war reviews documented that the compound's simultaneous use as a surgical agent and an interrogation tool was known to elements of both the medical establishment and the intelligence community, and that the compartmentalization between the two uses prevented systematic assessment of the compound's full psychological effect profile until after the war. The surgical complications were in medical files. The interrogation effects were in intelligence files. The veterans who experienced both categories of consequence, who had been anesthetized repeatedly for surgery, and who may have been subjected to interrogation procedures, had no mechanism available to them or to their post-war physicians for connecting what had happened to them in both institutional contexts. But here is where the conventional reading collapses into something stranger. The moral fracture at the center of the sodium pentothal story is not the dual use. The dual use is the mechanism. The moral fracture is the compartmentalization that the dual use required and produced. The surgical nurse who drew the compound into the syringe to induce unconsciousness in a soldier who needed surgery was working within a medical ethical framework that required consent, documentation, and follow-up. The intelligence officer who drew the same compound from the same kind of vial for an interrogation subject was working within an intelligence ethical framework that required classification, compartmentalization, and non-disclosure. Both frameworks governed the use of the same compound in the same war. The frameworks never spoke to each other. The people who received the compound in both contexts were not always distributed between two non-overlapping populations. The files are in different archives. The archives are in different countries. The compartmentalization was thorough. The consequences of the compartmentalization are still not fully assembled. Number 3. Heroin in the camps. In the winter of 1943, a British medical officer was standing in the improvised infirmary of a Japanese prisoner of war camp, reviewing a pharmaceutical distribution that the Japanese camp administration had made available for treating prisoners with respiratory conditions. He had been practicing medicine in the camp in the specific sense of a man who continues to practice medicine in the conditions that exist, rather than in the conditions that medicine requires. He had been treating prisoners with chronic cough for months, using whatever the camp administration provided and whatever could be obtained through the informal networks that prisoner communities build inside the walls that contain them. The pharmaceutical distribution in front of him was in Japanese packaging. He could read enough of the pharmaceutical labeling to identify the class of compound. He read the label. He stood still for a moment. The compound was diacetyl morphine. The brand name was different. The pharmacology was not. He was being asked to administer heroin to prisoners whose immune systems had been compromised by months of malnutrition and whose respiratory conditions had progressed to the stage where the compound would provide genuine relief. He administered it. The men with chronic cough needed treatment. This was what there was. How diacetyl morphine came to be present in Japanese military pharmaceutical supplies as a legitimate medical compound is not a story about deliberate cruelty or pharmaceutical warfare. It is a story about regulatory divergence. Western nations had progressively restricted and then prohibited the medical use of heroin across the 1920s and 1930s, following the recognition that the compound's high addiction liability made its clinical risk profile unacceptable relative to available alternatives. Japan had not followed the same regulatory timeline. Diacetyl morphine remained a legal pharmaceutical in Japan, available through standard pharmaceutical channels, used as an analgesic and cough suppressant as it had been used in Western medicine before the restrictions. The compound was in the Japanese military medical supply because it was in the Japanese pharmaceutical formulary. The Japanese camp administration that distributed it to Allied prisoners with respiratory conditions was distributing a compound it considered a standard pharmaceutical. What heroin does as a cough suppressant explains why it was genuinely effective for the conditions it was treating and why its effectiveness came at a cost that the effectiveness could not justify. Diacetyl morphine is rapidly deacetylated to morphine and 6-monoacetyl morphine in the body, producing its pharmacological effects through mu-opioid receptor binding with an onset speed and intensity that exceed those of pharmaceutical morphine administered at equivalent doses. The cough suppression mechanism is real. Opioid receptors in the brainstem cough center respond to opioid agonists by reducing the frequency and force of cough reflexes, which provides genuine relief for the chronic productive cough of respiratory infection. The dependency timeline in normal healthy subjects typically requires weeks of consistent dosing. The dependency timeline in malnourished and immunocompromised prisoners develops faster because the physiological depletion that malnutrition produces removes the buffer between therapeutic dosing and dependency-producing dosing. The documentary record of what occurred in Japanese prisoner of war camps regarding pharmaceutical distributions comes from multiple sources. Allied medical officers imprisoned in camps, including those along the Burma-Thailand Railway, documented pharmaceutical distributions in diaries and medical journals with the clinical precision that trained physicians bring to observation even under extreme duress. Sir Ernest Edward Dunlop, the Australian surgeon known as Weary Dunlop, kept detailed war diaries of his time as a prisoner along the Burma-Thailand Railway, published in 1986. Other Allied physicians in camps across the Pacific Theater similarly documented the pharmaceutical materials available and how they were used. These accounts collectively confirm that opioid compounds were administered to prisoners with respiratory and pain conditions across multiple camp settings, though the specific compounds and their sources varied by location and available supply. But here is where the nightmare begins. The liberation was celebrated with a thoroughness that the post-war medical system could not fully accommodate. The men coming off the ships from the Pacific were celebrated as survivors of extraordinary ordeal, and the medical assessment they received in the days immediately following liberation was oriented toward the physical consequences of malnutrition and injury, and the psychological consequences of captivity, rather than toward the pharmaceutical history of their treatment in the camps. The question of what compounds they had been receiving regularly for months was not the first question. It was in some cases not a question that was asked at all, because the medical officers conducting the liberation assessments had not been told that the camp pharmaceutical distributions were a category of information worth systematically collecting. The compound worked for the cough. It produced a dependency that the men carried out of the camp when they were liberated. The post-war medical system was not looking for it. The post-war medical system had not been told. Number 2. Paregoric. 18. That is the number of consecutive days that a Marine received Paregoric as treatment for dysentery at a forward aid station on Guadalcanal in the autumn of 1942. Not one dose in a moment of crisis. Not a short course that ended when the acute episode resolved. 18 daily doses of a camphorated tincture of opium, administered by a medical corpsman following the standard treatment protocol for dysentery in the Pacific Theater, in a soldier who could not leave his position for a base hospital because the tactical situation did not permit it, and because the forward aid station was the level of care available to him. He recovered from the dysentery. By the time the 18th dose had been administered and the dysentery had been controlled, and the protocol indicated that treatment could be discontinued, the nervous system receiving the daily opium preparation had learned something that the protocol's discontinuation did not address. He came home from Guadalcanal with two things he had not taken to it: the memory of the battle and the physical requirement for the compound that had managed his stomach. He did not know the second thing was there. No one had told him what Paregoric was. What Paregoric actually is requires separating the Victorian name from the pharmacological content, which is what a century of medical familiarity with the compound as a benign household remedy had made difficult to do. Paregoric is a camphorated tincture of opium in alcohol. The opium content is standardized at 45 milligrams per 100 milliliters of the tincture, which delivers morphine, codeine, noscapine, and papaverine in the proportions that naturally occur in the plant preparation. A standard therapeutic dose for dysentery delivers a measurable morphine equivalent. 18 daily doses deliver a cumulative morphine equivalent that is substantial in a context of regular daily administration to an opioid-naive patient. The dependency that develops does not develop on the 18th day. It develops across the progression of days as the nervous system responds to regular opioid receptor stimulation by adapting to that stimulation, reducing receptor sensitivity, and requiring the stimulation to maintain baseline function. By the 18th day, the withdrawal that would follow discontinuation would produce symptoms clinically indistinguishable from the symptoms of the dysentery that the compound had been treating. What Pacific Theater soldiers receiving prolonged Paregoric treatment actually experienced across the months of the campaign is documented in the fragmentary way of military medical records generated by systems under the pressure of combat operations. The Medical Department's Internal Medicine in World War II, Volume 2, published in 1963, documented Paregoric use rates across Pacific Theater operations that significantly exceeded what acute episode treatment would require, indicating widespread use for the chronic gastrointestinal conditions that men in prolonged jungle operations develop rather than for the acute dysentery episodes that the protocol was designed for. A soldier in the field with a gastrointestinal condition that was not resolving received repeated doses across weeks and months because the corpsman treating him had a supply and a protocol that specified Paregoric for gastrointestinal conditions and no clinical mechanism for distinguishing between acute episode treatment and the chronic administration that would produce dependency. Why Paregoric dependency was systematically underdiagnosed in the post-war veteran population is the forensic problem that the administrative gap between field medicine and the VA system created. The VA intake process was organized around the medical record that the veteran carried out of the military system. Field corpsmen medication administration under standard treatment protocols was not a category of medical event that generated the same documentation as a surgical procedure or a hospitalization. The corpsman who administered Paregoric on 18 consecutive days at a forward aid station did not generate 18 individual prescription records. He administered a standard treatment under a standard protocol. The VA physician who saw a Pacific veteran presenting with abdominal cramps and anxiety and insomnia saw a combination of symptoms consistent with tropical disease sequelae and combat trauma. The differential diagnosis between opioid withdrawal and those conditions required a medication history that the record did not contain. But here is where the nightmare begins and does not end. The Paregoric pathway is the item on this list that scales most directly against the total Pacific Theater troop strength, because Paregoric was standard issue, and dysentery was nearly universal in the Pacific campaign. The number of Pacific Theater veterans who received the compound is not a small number or a specialized subset. It is a population that overlaps substantially with the total population of men who served in the Pacific Theater for extended periods. The compound worked for the dysentery. The dependency came home with the recovery. The VA form did not ask what the corpsman had given them in the foxhole. The answer was in the men. The question was not in the form. 18 days times a population measured in the hundreds of thousands times a molecular weight that the nervous system does not forget is a number that the post-war medical system never assembled, because the post-war medical system had not been designed to know that it needed to. Number 1. CBI Theater Raw Opium. In the spring of 1944, a Merrill's Marauder Battalion medical officer was treating a soldier with an infected leg wound at a forward position in the Hukong Valley of northern Burma, when the supply situation produced the specific crisis that the field medical system had not designed a protocol for. The Morphine Syrettes had run out days earlier. The resupply that the medical section had requested had not arrived. What the medical officer had obtained in the intervening days, through the informal supply network that the relationship between the marauders and their catch and scout contacts had produced, was a small quantity of raw opium from a village where the compound had been grown and processed and traded for longer than any military formation in the valley. He was measuring a preparation from this material. The procedure was not in any field manual. The compound was not in any military pharmaceutical formulary. The dose was not standardized against any pharmaceutical specification. The patient had an infected wound and needed pain management. This was what there was in the Hukong Valley in the spring of 1944, when the pharmaceutical supply chain had reached its furthest extent and stopped. What the China-Burma-India theater looked like as a pharmaceutical supply problem is best understood from its geography before its military history. The CBI theater was secondary in the allocation of supply chain resources to a logistics architecture built around the primary theaters and treating the CBI as the end of the line. The supply chain that kept the major theaters adequately provisioned with morphine syrettes and other pharmaceutical compounds did not reach the Hukong Valley at the rate that major theater consumption figures would have predicted. It reached the main bases. It reached the forward depots. At the far end of the supply chain, where Merrill's marauders were operating against Japanese forces behind enemy lines, in terrain that made aerial resupply difficult and ground resupply impossible, the pharmaceutical gap was not an occasional inconvenience. It was the baseline condition against which field medical practice operated, and against which the catch and supply networks were the only consistently available alternative. Charlton Ogburn, who wrote The Marauders, published in 1959, documented field conditions including medical improvisation in the Hukong Valley with the specificity of someone who had been present in the operations he described. What raw opium is, and how it was administered in field conditions, is the pharmacological dimension that distinguishes this item from every other item on this list, in terms of the dose uncertainty it produced. Raw opium is the latex harvested from Papaver somniferum seed pod incisions, dried to a consistency that allows handling and storage, containing morphine, codeine, thebaine, papaverine, and other alkaloids in proportions that vary between growing regions, cultivation conditions, and harvest timing. The morphine content of raw opium preparations varies between approximately 8 and 15% by weight, meaning a preparation made in the field from a village supply could deliver nearly twice the morphine dose of a preparation made from a different batch without any visible difference between the two. Pharmaceutical morphine is standardized to eliminate this variability. Raw opium in field conditions has no standardization mechanism. The medical officer administering a preparation from locally sourced raw opium was administering an analgesic whose dose was approximately right, rather than precisely known. To a patient whose response to an uncontrolled dose preparation, he could not predict with the precision that the pharmaceutical supply chain was designed to produce. The dependency that developed with repeated administration of raw opium was not a different kind of dependency from the dependency that developed with pharmaceutical morphine. It was the same dependency, produced by the same receptor mechanism, with the additional risk factor of dose variability that could accelerate its development or produce acute toxicity in ways that standardized pharmaceutical administration was specifically designed to prevent. What theater physicians and medical officers recorded about raw opium use in the CBI is a documentary record whose character differs from the records produced in major theaters in the specific way that field medicine records differ from hospital medicine records. References to local pharmaceutical procurement in the accounts of those who served in CBI operations appear matter-of-factly, reflecting the conditions rather than the ethics of what was occurring. The field medical record for a patient treated with locally obtained raw opium might describe an analgesic administered, local preparation, which is accurate and does not constitute documentation that a VA physician reviewing the file years later would identify as evidence of opioid exposure. The gap between what occurred and what the record said about it was produced by the field documentation system's inability to accommodate a category of pharmaceutical event that the system's designers had assumed would not occur. The designers had assumed the supply chain would reach the patient. The supply chain had not reached the patient. The record reflected the assumption rather than the reality. The moral fracture that the CBI raw opium story exposes is the fracture between the pharmaceutical standard of care that the military medical system claimed to provide and the pharmaceutical reality it produced at the edges of the supply chain it maintained. The military medical system of the Allied nations in the Second World War was the most sophisticated pharmaceutical system that had ever been deployed in the field. It produced penicillin and plasma and blood banking and surgical innovations that changed medicine permanently. It also produced a gap between the center of its supply chain and the edge of its supply chain that was wide enough that men in the Hukong Valley were receiving the analgesic of the ancient world because the analgesic of the pharmaceutical century had not arrived. The gap was a structural failure of an institution that had not built its supply chain to match its claim about the standard of care it was providing. The medical officer administering raw opium in the Hukong Valley was doing what the supply chain failure had made necessary. The supply chain failure was not his to address. It was the institution's to acknowledge, and the institution's post-war accounting did not include an acknowledgment of the pharmaceutical reality at the furthest extent of its reach. The war ended in August 1945. The pharmaceutical companies issued statements about the Morphine Syrettes and the penicillin. The supply chain administrators submitted reports about the quantities delivered to the major theaters. In the Hukong Valley and on the Ledo Road, and at the forward positions that had been beyond the supply chain's reliable reach, the soldiers who had been treated with what the local environment provided came home carrying what dependencies that the official pharmaceutical record of the CBI did not document, because the official pharmaceutical record documented the supply chain rather than what the supply chain had failed to supply. The official record shows pharmaceutical modernity. The field accounts show something older, 3,000 years older, in a valley where the plant had been grown for exactly that long and where the pharmaceutical century had arrived with Merrill's marauders and had not quite made it to the furthest forward position before the Syrettes ran out. The soldiers came home. The dependency came with them. The official record calls it improvisation. The men who were there called it what it was, which was the only thing available, which was enough to keep a man functional when the alternative was agony in the Hukong Valley in the spring of 1944, with Japanese forces on 3 sides and the pharmaceutical supply chain on none of them. If you want to see more videos like this, click the video on screen now and make sure to subscribe.